you're going to have your patient supine. And I'll do an active range of motion assessment first. So, Sarah, what I'm going to have you do is you're going to bend at your hip here and come up like this, as high as you can. Okay, so can you do that for me? Good. And then I might do a little bit of passive range, just to see how far I can get her. All right, so when you do goniometry for this,
And the end feel is what?
Soft.
okay,
Although sometimes it does feel firm because there really is a stretch on the hip extensor.
yeah, like if they have really tight hamstrings or tendons that there. Okay, so your axis when you measure hip flexion is going to go on the lateral aspect of the greater trochanter. So when you go to find this, what you can do is bring the patient's leg out like this, and right where you can feel a little bit of a depression.
Why don't we all
right
feel
there.
our greater trochanter now? Let's stand up and do it so we can all feel it.
So if you go out like this, that's right where that depression is.
Put your thumb on the top of your iliac crest and bring your middle finger. And all our hand length is different, but it's about this breadth. And then go into hip abduction. And you're going to feel a little bit of a depression. You feel that? Has everybody got their greater trochanter? This is something you can do when you're waiting for the bus and you don't know what else to do. You can check your greater trochanter and see what it is. Did everybody find it? Yeah. Feel pretty good about it? Keep checking it all week. Nobody gets my number.
Alright, so that's where your axis is going to go. Your stable arm is going to be in line with the trunk. Your movable arm is going to be parallel to the femur. Alright, Sarah, we're going to do that same motion again. You bring your leg up, and it's okay if the knee bends with it. It's supposed to.
And Jamie created these great handouts with all this information. She's going to send it to you. So, I mean, you can write if you like to write, but she's going to send it.
Okay, and she gets to about 105 passively. Oh, there you go, or actively. Okay, 110 actively. So now I'm gonna see if I can get her to the normal, which is 120.
Great gunner.
And you, yeah, well, you're at 120. 122. Good job. Okay, so that's hip flexion. Is there any questions with that one?
A substitution, and this, your book always says, for everything, what does it say? Just check the pelvic and lumbar area, but I think that a substitution would be that someone doesn't head straight into hip flexion, and so they tend to externally rotate or internally rotate. To me, that seems like if you're going to do it with a patient, they might do this, or they might do that. So keeping that hip straight would be, to me, a real easy substitution to remember. And I try to keep it easy. Fine.
What would the plane of motion be for this one?
Sagittal.
And axis of rotation?